The topic of today, actually, it is the most important topic of endocrinology. Today, we are going to be speaking about diabetes mellitus. First, I'd like to give you the websites of the most important and the most famous organizations addressing with the issue of diabetes. The American Diabetes Association, the American Association of Clinical Endocrinologists, the European Association for Study of Diabetes, and the International Diabetes Federation. All these organizations actually they have a specific website and they offer free material to give the latest updates regarding the research, treatment, and everything related to diabetes mellitus. And actually lots of the material which will be presented in this lecture, actually I got it from the Diabetes Care or the Standards of Medical Care in Diabetes, and this is the most important journal and it is issued by the American Diabetes Association. And as you can see here, many of the material that will be contained in the lecture will be actually from this issue, which was issued in January 2020. The lecture outline will speak about the introduction, and then the physiology and pathophysiology, classification and diagnosis of diabetes, and how to evaluate a diabetic patient. And then we will speak in more details about type 1 diabetes, type 2 diabetes, and hypoglycemia, and finally, we will finish the presentation with the chronic complications of diabetes. First, I'd like to give you an introduction. What is the definition of diabetes? The hallmark of all forms of diabetes is hyperglycemia. And hyperglycemia, it results from a defect in the insulin secretion, insulin action, or both. Which means that there are certain situations, for example, in a hospitalized patient, that you will find him hyperglycemic. Not necessarily that this patient might be diabetic, but the management will be the same. In other words, hyperglycemia, whether due to diabetes or stress hyperglycemia, which is very frequent happening in the hospital setting, will be managed along the same lines as any patient with diabetes. Now, in order to understand why are we so much concerned and why I do consider this is the most topic in endocrinology, is actually we need to understand what is called the global diabetic epidemic. Have a look on this map and you will be surprised to find that by the year 2015 you got almost 4 million patients diagnosed with type 1 and type 2 diabetes. It is expected that this number will jump into the year 2040, which will be about almost 700 million people affected with diabetes. And this figure actually represents both type 1 and type 2. Now, the prevalence of diabetes, according to the statistical figures issued in 2015, it was 1 patient in every 11 adults, you will have him to have diabetes. And regarding the situation in our country, Egypt, and along the Saudi Arabia and the other Gulf countries, actually, they have the highest prevalence of diabetes. As you can see in this map, it is highlighted in the color of dark red. And Egypt, actually, it is ranking number 8 regarding the top 10 countries with the prevalence of diabetes. And another point in order for you to understand what is the importance of diabetes. Diabetes, actually, it is the 4th common cause for a consultation in medical practice. Diabetes, it is the leading cause of blindness, it is the leading cause of end-stage renal disease and non-traumatic limb amputations. And diabetes, the presence of diabetes, which is actually part of the risk factors, increases the risk of cardiac, cerebral, and peripheral vascular disease. Remember, there are what's called the major risk factors in cardiovascular system. The major risk factors actually which will accelerate the process of atherosclerosis, and they put the patient at risk of cardiac, cerebral, and peripheral vascular events. Diabetes is one of the important risk factors which will predispose to these catastrophic events. Egypt, as I mentioned, actually it is one of the countries along the top 10 countries regarding the prevalence of diabetes. And as you can see here, the prevalence of diabetes in Egypt, it's actually around 11.4 or 12%, which is again a very high prevalence rate. Basic physiology and pathophysiology. This is a very crucial point to understand, because understanding physiology and pathophysiology will have a very important implication in the understanding of the treatment and the management of diabetes as a whole. The insulin which is produced by the pancreas, it's actually produced by the islets of Langerhans. If you remember, the pancreas, it has an exocrine and endocrine functions. The exocrine function actually is carried by 80% of the pancreatic or pancreas as a gland, and 20% actually it is the endocrine part. The endocrine part, or the islets of Langerhans, actually it contains three types of cells. The alpha cells, which produces glucagon, the beta cells producing insulin, and finally the delta cells, which produces the somatostatin. And what are the factors which will control insulin secretion, or actually what are the stimulators and inhibitors? Insulin is produced in response to glucose, amino acids, acetylcholine, theophylline, and sulfonylurea. On the other hand, insulin secretion will be suppressed by somatostatin, beta-adrenergic blocker. And this is a very important fact, because actually when you get, for example, a diabetic hypertensive patient, actually it will be unwise to choose beta blockers for treatments, as beta blockers will suppress the insulin secretion. And also insulin secretion is suppressed by thiazide diuretics. And this is a very common side effect of thiazide diuretics. If you recall, thiazide diuretics, they have three important side effects. All of them start with the hyper. Thiazide diuretics produce hyperglycemia and hyperuricemia. And also potassium depletion, it suppresses the insulin secretion. Insulin secretion, this diagram, it represents the pancreatic beta cells. Once glucose enters into the cell, it will stimulate the production of adenosine triphosphate. Adenosine triphosphate actually will enhance the entry of calcium inside the cell. The entry of calcium will actually result in the rupture of the vesicles containing a pre-made insulin. And the normal insulin secretion, actually it occurs in two phases, or a biphasic two stages. When you eat a meal and the elevation of blood glucose, the elevation of blood glucose, first it will release the preformed insulin. But as the blood glucose continues to be elevated, this will result in more stimulation of the pancreatic beta cells, resulting in de novo synthesis. And this is apparent from this diagram. In this diagram, let's have a look here on the part which is labeled as A. You will find here that the first phase of insulin is a very quick phase, and this very quick phase, it represents the release of the preformed stored insulin in the vesicles. The second phase, which is actually a more plateau phase, it represents de novo synthesis of the insulin. This is very important to understand, that the insulin secretion occurs in two phases. The first phase, in which there is a release of the preformed stored insulin. The second phase is a more sustained, slow release phase, which represents the de novo synthesis of the insulin. Now, what are the effects? It is very important to understand that insulin, it has its major effects on three principal tissues: adipose tissue, liver, and muscles. Of course, you don't need to remember all these actions, but I am highlighting here in red the important actions that you need to remember. Effects of insulin in adipose tissue. It enhances the glucose entry, it enhances the utilization of fatty acids in order to produce triglycerides, and it suppresses a hormone which is called hormone sensitive lipase, which results in breaking down triglycerides. In other words, insulin, it enhances glucose entry and it enhances lipogenesis, which is synthesis of triglycerides, and it suppresses lipolysis. In the liver, it enhances glycolysis. What is glycolysis? It is a utilization of glucose, and it increases or it enhances glycogenesis, which is synthesis of glycogen from glucose. In the muscles, it enhances the utilization of glucose and it suppresses the protein catabolism, and it also suppresses the release of the gluconeogenic amino acids. In other words, insulin suppresses gluconeogenesis. What is gluconeogenesis? Gluconeogenesis, it is the synthesis of glucose from non-carbohydrate source. Now, this is another diagram, or this is another table, which actually summarizes the overall action of insulin. On carbohydrate metabolism, it enhances glycolysis and glycogen synthesis, or glycogenesis, and it suppresses glycogen breaking down. Glycogen breaking down is called glycogenolysis, and it also suppresses the gluconeogenesis, which is the synthesis of glucose from non-carbohydrate source. on protein metabolism, it enhances utilization of amino acids, it enhances protein synthesis, and it suppresses proteolysis, which is breaking down the protein. On the lipid metabolism, it enhances glycogenesis, which is, it enhances lipogenesis, which is the synthesis of triglycerides, and it suppresses the lipolysis. Now, when we discuss what are the various factors which will control the blood glucose level in both fasting and postprandial states, the two factors which regulate the blood glucose level during the fasting state, number one, the liver sensitivity to insulin and the liver production of glucose. When you have what we call basal level or a very small sustained level of insulin when you are fasting, actually it suppresses the production of glucose through suppressing gluconeogenesis. And this occurs because the liver cell is normal liver cell, it is sensitive to insulin. So during fasting, the sensitivity of the liver cell to insulin, the small amount of insulin which is produced during fasting, it maintains your blood glucose level stable and not increased because it suppresses the production of glucose through suppressing gluconeogenesis. After eating or postprandial, the factors which regulate the blood glucose level will be the preprandial glucose during fasting and how much glucose is presented or it is given through the load from the meals, and the efficacy of the pancreas to produce insulin, and finally the insulin sensitivity of the peripheral tissues. In other words, when you get glucose loads, when in a normal pancreas it produces a normal amount of insulin which will enhance the utilization of glucose by the normally produced insulin from a normal pancreas. Accordingly, when you get a patient with diabetes, you get fasting hyperglycemia, although he is not eating, however, he still will have hyperglycemia. Why? Because there is a deficiency of insulin production, which will result in increase in the level of glucagon. Remember, both insulin and glucagon produced by two different types of pancreatic cells, they are counterbalancing each other. When you get insulin deficiency, you will get increased glucagon. Increased glucagon will result in enhanced gluconeogenesis in the liver, which means in a diabetic patient, even if he is not eating, he will still have fasting hyperglycemia because of the enhanced gluconeogenesis in the liver caused by increased glucagon caused by insulin deficiency. At the same time, after he eats, it is quite expected that a diabetic patient will have hyperglycemia because you have impaired insulin secretion, which is not proportionate to the glucose loads presented during the meal, and you will have increased glucose production by the liver, and you will also have decreased utilization of glucose by the skeletal muscle. All these factors together will contribute to hyperglycemia in a diabetic patient. This is a nice diagram which also it explains in more details what are the contributing factors for hyperglycemia in diabetic patients. An important thing in diabetic patients, they have also a central defect in the brain which actually suppresses the satiety, which means a diabetic patient, he continues to eat even when he is not feeling the sense of hunger. And the same thing regarding the liver. When you have a look here on the liver, enhanced gluconeogenesis, on the pancreas, decreased insulin secretion and increased glucagon secretion. A very important thing, decreased production of what we call glucagon-like peptide secretion from the intestine, and we will address this issue in more details when we start discussing the newly developed drug, which actually called the drugs which have the incretin effect. Have a look here on the muscle, decreased glucose uptake because of the deficiency of insulin, and enhanced lipolysis, which will provide a substrate for the production of glucose. Now we come to the classification and the diagnosis. What are the different types of diabetes and how can we diagnose diabetes? Diabetes is now classified into type 1 and type 2 gestational diabetes and specific types of diabetes. Type 1 diabetes, it is actually related to an immune-mediated destruction of the pancreatic beta cells. Type 2 diabetes, it is caused by the progressive loss of the pancreatic beta cells to produce insulin, and we have a combination of insulin resistance and defective insulin production. Remember, in type 1 diabetes, there is an entire destruction of the pancreatic beta cells. It is an immune-mediated process which will lead to absolute insulin deficiency. In type 2 diabetes, initially there is a preserved amount of insulin produced. Gestational diabetes, it's very important to understand this expression. Gestational diabetes is a patient who is diagnosed diabetic for the first time in her life during the second or the third trimester. It doesn't apply to a diabetic patient who becomes pregnant. So gestational diabetes, it is a pregnant lady diagnosed with diabetes for the first time in her life. And the last type of diabetes, which is the specific type of diabetes. Type 1 diabetes, it represents less than 10%, and as we mentioned, it is caused by entire immune destruction of the pancreatic beta cells. Now, the old nomenclature, which is juvenile or insulin dependent, is no longer used because there is a subtype of type 1 diabetes, which is called late onset autoimmune diabetes. In other words, you can get type 1 diabetes in a patient, for example, who might be 45 or even 50, because in this case, the immune-mediated destruction might be slow and the presentation of type 1 diabetes might actually take decades in order to reveal itself. Now, type 1 diabetes is characterized by entire dependence of insulin. So, exogenous insulin is important, and it is not only needed to control the blood glucose, but it is also needed to prevent diabetic ketoacidosis, which is one of the drastic complications of diabetes. In other words, insulin is a mandatory medication for type 1 diabetes in order to preserve life. Type 2 diabetes, which represents the majority of cases, and again, it is no longer called maturity onset, and it is no longer called insulin independence, because actually, many cases with type 2 diabetes, now we meet some children who are having type 2 diabetes because of their overweight and bad dietary habits, and many cases of type 2 diabetes, they start by good response to oral medication, but eventually, they will be actually dependent on insulin. So remember, the old nomenclature of maturity onset or insulin independent is no longer used. The importance of type 2 diabetes, which is one of the risk factors, it is very commonly associated with overweight and hypertension and hyperlipidemia. Gestational diabetes, it is the occurrence of diabetes for the first time in a pregnant lady during the second and third trimester. Why the second and third trimester? Because this is the time during which there is a peak of production of placental hormones. Now, the importance of gestational diabetes, that after delivery, some cases actually they will resume the normal glucose tolerance, and this should not give this false sense of security, because 60% of the females, pregnant females who were diagnosed as gestational diabetes, they will develop frank type 2 diabetes within 5 to 10 years, which means any pregnant lady who is diagnosed with gestational diabetes should have a close follow-up at least for 3 or 5 years after delivery to make sure that she will not develop frank type 2 diabetes. The specific type of diabetes, actually we have some endocrinal diseases which can produce diabetes as a secondary, or the old nomenclature secondary diabetes. For example, cases of Cushing syndrome, acromegaly, diseases of the exocrine pancreas, chronic pancreatitis, because chronic pancreatitis will result in destruction of the endocrinal part, so this is also categorized as specific type or drug-induced. Now, a specific type of the diabetes is called monogenic diabetes. Monogenic diabetes, why is it called monogenic? Because this specific entity, which is the monogenic diabetes, it actually results in one single gene defect, gene mutation, which results in beta cell dysfunction. And one of the very famous types of the monogenic diabetes is what is called the MODY. What is MODY? It is the maturity onset diabetes of youth, and previously it was wrongly classified as a subtype of type 2 diabetes. But now, because of the advances in the technology and our understanding of the genetics, the MODY actually is categorized as a monogenic diabetes. Monogenic diabetes, it's actually a gene mutation. One single gene mutation results in defects of the pancreatic beta cell function. The monogenic diabetes, which is the MODY, actually it includes more than one subtype. The most common type is the MODY type 3. And it is characterized by hyperglycemia at an early age, but usually the hyperglycemia is not severe as type 1 or type 2, and usually it results from the impaired insulin secretion because of the gene defects, and usually those patients are not obese, and most important, they have a strong family history. The importance of recognizing the specific types or the monogenic diabetes, that some cases of MODY actually, which can be wrongly diagnosed as type 1 diabetes, they can respond well to a very low dose of sulfonylureas instead of initiating insulin therapy based on the incorrect diagnosis of MODY types into type 1 diabetes mellitus. What are the diagnostic criteria? When can we diagnose a patient with diabetes? Diagnostic criteria. Number 1, A1C more than 6.5. Symptomatizing patient taken with random blood glucose level more than 200 milligrams per deciliter. Fasting blood glucose, and by fasting we are talking about fasting at least for 8 hours, more than or equals 126 milligrams per deciliter. 2 hours postprandial, more than 200 milligrams per deciliter. And we need to address here that postprandial we have to be using the standard 75 grams oral glucose, not a conventional diet. So these are the diagnostic criteria of diabetes mellitus. Now, it was found that there are certain groups of people who are categorized as a prediabetes. What is prediabetes? Prediabetes, before we speak about prediabetes, I'm here just reminding you about the risk factors for the atherosclerosis. As you can see here, it includes smoking, dyslipidemia, hypertension, and diabetes. And one of the important risk factors here, what we call the metabolic syndrome. Metabolic syndrome is a constellation of symptoms and signs which includes abdominal obesity, insulin resistance, hyperglycemia, elevated blood pressure, and elevated lipid level. And these are the diagnostic criteria of the metabolic syndrome. The people with metabolic syndrome, they have a defect in the carbohydrate metabolism, they have abdominal obesity, you have dyslipidemia, and they also have hypertension. Now, we go back to the definition of prediabetes. It was found that certain people, they have blood glucose levels, which actually do not meet criteria of diabetes. At the very same time, these levels are too high to consider them normal. So it was put that these pre-diabetics actually, they are actually occupying what I call the gray zone. If we assume that a normal person will be in the white zone, a diabetic patient will be in the black zone, the pre-diabetes actually is standing in the gray zone. In other words, if we don't correct the risk factors and if we don't correct some of the metabolic derangements, he will develop a frank diabetes. Now, what are the criteria for diagnosing prediabetes? Number 1, fasting blood glucose. Fasting blood glucose within the range between 100 and 125. This entity is called impaired fasting. We have another entity which is called impaired glucose tolerance. Impaired glucose tolerance meaning after 2 hours you will find that the blood level it is from 140 to 199. Remember, when the fasting blood glucose reaches 126, it is no longer prediabetes, it is diabetes. And the same thing for the 2 hours postprandial. If it reaches 200, so it will be a frank case of diabetes. The third criteria for the prediabetes is to have A1C between 5.7 and 6.4. So this diagram actually it represents the normal levels for the glucose tolerance and the prediabetes. In a normal person, A1C should be less than 5.7, fasting less than 100 mg per deciliter, 2 hours postprandial less than 140. If the A1C somewhere between 5.7 and 6.4, or if the fasting glucose between 100 and 125, and if the 2 hours postprandial between 140 to 199, this defines prediabetes. Prediabetes, once you diagnose them, you have to instruct them to follow a clear guidelines regarding a healthy lifestyle, diet regulation, and in certain selected cases, if they are overweight, we can start metformin as a medication, as we shall discuss later. Again, this table, it represents the normal levels of blood glucose, the impaired or pre-diabetes, and the diabetes. It's very important to remember these figures very, very well. The normal levels for the blood glucose, the impaired or the pre-diabetes, and finally the diagnostic criteria for diabetes. This table actually have a look here on type 1 and type 2. Type 1, which is actually representing with a green arrow going in one direction. Because once you have diabetes in type 1 diabetes, there is no going back and the patient should be receiving a treatment. But have a look here on type 2 diabetes and gestational diabetes. Actually, it is a bi-directional arrow in certain stage. In other words, when you diagnose type 2 diabetes in the pre-diabetes stage, the glucose metabolism can actually resort back to normal. The same thing for the gestational diabetes, because once patient with type 2 or gestational diabetes, they develop frank diabetes mellitus according to the diagnostic criteria, you have to institute drug therapy. Now, when you are confronted with a diabetic patient, what are the items that you should be asking for and what are the items that you should be looking at when you are examining him? First, you have to define the age. You have to define the eating patterns, very important. The eating patterns, according to it, actually will result in the selection of the timing of the medication. You have to inquire about previous treatment regimens. You have to ask about hypoglycemic episodes, and very important, you have to inquire about history of complications. We shall discuss these complications in full details in part 3, which will include microvascular, macrovascular, and other complications. Now, when you are doing the examination, you have to focus on the height, the weight body mass index, blood pressure, fundus examination. You have to examine the oral cavity because gingivitis and oral cavity infections are very known things in diabetic patients. You have to examine the thyroid because in certain cases of diabetes there are associated thyroid dysfunction. You have to examine the skin very carefully, and a very important aspect of the examination is the examination of the lower limbs, which will include inspection, palpation for the dorsalis pedis artery. You are concerned about macrovascular complications and peripheral vascular disease. You have to do a detailed neurologic examination because you are concerned with the microvascular disease. Now, the laboratory evaluation will include the blood glucose levels, the lipid profile, and you need to check for the possible of diabetic nephropathy by a test which is called urine albumin excretion or albumin creatinine ratio. And don't forget to evaluate the thyroid because associated thyroid disease is very common in certain types of diabetes. So the management of diabetes will include 3 things. Your first task, number 1, is to achieve blood glucose control. The second task is to have to treat associated conditions. Remember, in type 2 diabetes, there is a high possibility that this patient might have hyperlipidemia or obesity or hypertension. And finally, you have to screen for the complications that we shall discuss later on in full details, including the micro and the macrovascular complications. This concludes part 1, and we shall continue in part 2.